4, 3, 2, 1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. NMD tetraplegia. Dog signalment. 3-year-old spayed female red-bone coonhound. Coleman chief complaint. Recumbent. With no voluntary movement examination. Video 5-1 shows the total flaccid paralysis of the entire neck, trunk, limbs, and tail. It spares anal tone and the cranial nerves, except for a slight facial paresis. Despite the diffuse atonia and areflexia, nociception was intact. The only evidence of this was the movement of the jaw and eyes. No voice was audible because of the lack of expiratory effort. Anatomic diagnosis. Diffuse neuromuscular disease differential diagnosis. Acute polyradiculoneuritis, botulism, acute fulminating myasthenia gravis, tick paralysis, polymyositis, snake envenomation, organophosphate toxicity. Polyradiculoneuritis. Acute polyradiculoneuritis, PRN, is an immune-mediated disorder of myelin or axons or both that usually presents as an acute or per-acute onset of diffuse LMN paresis that usually progresses rapidly to tetraplegia. There may be a history of possible exposure to a raccoon bite, but that is not a requirement for this diagnosis. Paresis often begins in the pelvic limbs, but not always. Owners often recognize a voice change because considerable loss of its usual volume is evident. Some owners describe the voice change as hoarse. This may be the first clinical sign recognized. Tetraplegic dogs may have no audible voice. Cranial nerves are spared except for a few dogs that have a mild facial paresis. Megaesophagus is not seen in this disease. Chronic forms exist, in some of which the severity of the clinical signs may wax and wane, but tetraplegia does not usually occur. No evidence of any sensory loss exists because the major site of the lesion is in the ventral roots, which is the basis for the term radix in the name of the inflammation, figures 5-11 and 5-12. However, some dogs may appear to be hyperesthetic, for which hypotheses exist but no proven explanation. Possibly some of the inflammation extends into the spinal ganglion, dorsal root, or both. Muscle atrophy is observed by 7 to 10 days and rapidly becomes very severe. In the human literature, this polyradiculoneuritis is referred to as inflammatory polyneuropathy, which seems to be a superfluous term as an inflammation of nerves is a neuritis. It is also known as Landry-Guillain-Barré disease, which is the most common cause of total paralysis in humans today. Some forms cause predominantly a primary demyelination with axonal sparing, others affect primarily axons, and the demyelination is secondary. Strong evidence suggests that molecular mimicry is involved in the pathogenesis. In this mechanism, the patient's immune system is exposed to an exogenous antigen such as the bacterium Campylobacter jejuni, in which the lipopolysaccharide capsule of the bacterium has components that act as antigens that are similar to the gangliosides found in the myelin of the patient's PNS. The antibodies formed by the immune system attack and destroy the nerve's myelin, recognizing it as being similar to the bacterium's lipopolysaccharide capsule. Other exogenous antigens have components that mimic molecules found in axons. The degree and rate of recovery is dependent on whether the immune system is directed primarily at the myelin sheaths or the axons. The former recover faster and more completely because of the remarkable ability of the Schwann cells to proliferate and remyelin at the intact axons. Electrodiagnostic testing may help contribute to determining the prognosis by indicating which portion of the nerve is more affected. Recovery may take a few weeks to many months. It is assumed to be a reflection of the degree of axonal involvement. Occasionally, recovery does not occur. Other infectious agents implicated in this immune system pathogenesis are Mycoplasma pneumoniae, cytomegalovirus, and Epstein-Barr virus. The antigenic stimulus in dogs is unknown. Because of the high incidence of this disease in the dogs used to hunt raccoons, the saliva of the raccoon is thought to be a source of the antigen involved in this molecular mimicry. This is the reason the disorder is often called coonhound paralysis. There may also be a genetic predisposition for this PRN in breeds of coonhounds. In our attempts to reproduce the disease using raccoon saliva, it was successful only in coonhounds that had previously had the disease and had recovered. However, it is important to know that exposure to raccoon saliva is not required for this disease to occur. This supports the theory that other sources of antigen have not yet been discovered. We believe that to acquire PRN, two conditions must be satisfied. One is the exposure to a specific antigen, which can have a variety of sources. The other is that some alteration that may well have a genetic basis has to have occurred in the immune system of the patient. In humans, this PRN occasionally follows a vaccination such as a flu virus, yet only a very small portion of individuals who receive this vaccine develop PRN. The high rate of recovery from PRN suggests that the immune system disorder is short-lived. This is supported by the fact that immunosuppressive drugs do not appear to enhance the recovery, and repeat exposures to raccoon saliva may induce another episode of PRN. Dr. John Cummings and I studied one red-bone hound that had the disorder 5 times but recovered completely from each episode. In large kennels of working coonhounds, repeat episodes are common. Diagnosis is based primarily on the characteristic clinical appearance of a rapidly progressive LMN tetraparesis to tetraplegia. No ancillary procedures will confirm this diagnosis of PRN. Cerebrospinal fluid, CSF, evaluation that shows a significant elevation of protein, with or without pleocytosis, is strongly supportive of this diagnosis but requires general anesthesia. The CSF changes occur because the nerve roots, where the lesion is most pronounced, are bathed in CSF. Most of the ancillary procedures that are used help rule out the other disorders in the differential diagnosis, including intravenous etrophonium, tensilin, serum antibody levels for acetylcholine receptor antibodies for myasthenia gravis, and serum enzyme levels for polymyositis. Nerve biopsies are non-specific because the primary non-suppurative inflammation is most prevalent in the ventral roots and spares the more peripheral part of the nerves. Treatment involves rigorous, persistent nursing care. Placing the patient on a waterbed is the best way to prevent pressure-induced skin ulcerations. In a rural environment, bed the patient in a stall with many feet of straw, and change the soiled straw daily. These dogs should be turned over hourly. They usually are able to defecate and urinate if they are supported and helped by abdominal pressure. The cranial nerves involved with prehension and swallowing are unaffected, but the patient will have to be supported to eat and drink. A regular daily schedule of physical manipulation and muscle massage is recommended. With a recent interest in physical therapy and veterinary medicine, facilities are now available to aid in the treatment of these patients. Be patient. It may take many weeks for recovery to evolve. We have observed patients that required 4 to 6 months before they could stand and walk. In humans with severe signs of PRN, intravenous Greek letter gamma globulin and plasmapheresis have been effective treatments, but no reliable data on their use in animals are available. PRN is occasionally seen in cats but is rare in other domestic animals. On the basis of the examination of the red-bone coonhound, Coleman, mentioned above, and prior to any ancillary procedures, PRN is the most presumptive clinical diagnosis of the disorders listed in the differential diagnosis. Botulism is a diffuse LMN disorder caused by the toxin produced by the bacterium Clostridium botulinum. At least 8 neurotoxins have been recognized. The organisms that produce these toxins vary in their geographic location. The type B producing organisms are common in the mid-Atlantic states, where foals are abundant and are commonly exposed. Species differences exist in susceptibility to botulism as well as to the specific types of neurotoxins. Dogs, cats, and pigs are the most resistant to botulism. In affected dogs, the type C neurotoxin is most commonly involved. Ruminants and horses are highly susceptible, and deaths are common. Cattle are most commonly affected by the type C and D neurotoxins, and horses by types B and C. Intoxication may occur by 3 methods. The most common is through the ingestion of a preformed neurotoxin in a feed source. Hay and silage are often implicated, but the identification of the feed source is often very difficult. Dead infected animals are a source for carnivorous animals. A second and common method of intoxication in young animals, especially foals, is through the absorption of a neurotoxin that is produced within the gastrointestinal tract from spores that have been ingested from the environmental soil. This method is referred to as toxico-infectious botulism. A third but rare method is the circulation of toxin produced by organisms growing in the anaerobic environment of an infected wound. This is wound botulism. Ingestion of toxin from a feedstuff available to a herd of animals may cause a significant loss of animals. This occurs most commonly in cattle. More often, individual horses are affected, but herd outbreaks may occur. Foals are especially at risk when they ingest the bacterial spores from their environment, and the toxin produced in their digestive system becomes absorbable. These have been referred to as shaker foals because of the diffuse muscle tremors that occur when they are standing and walking. Without antitoxin therapy, the mortality rate is very high because of paralysis of the respiratory muscles. In some circumstances, an excessive growth of this bacterium in the intestine of adult horses may be the source of intoxication. Dogs and cats are relatively resistant to botulism, and if removed from the source of the toxin, they usually recover in a few weeks. Kennels of hunting dogs may be exposed to the toxin in a feed source. An individual dog may be exposed to the neurotoxin present in a dead animal that it consumes. Beware of dead birds in public parks, where dogs often run free. The mechanism of action of the neurotoxin is at the neuromuscular junction, where the neurotoxin binds to receptors on the axon terminal. It translocates into the axon and interferes with the release of acetylcholine. Because this affects only neuromuscular junctions, all the clinical signs are limited to LMN deficiency. No sensory system signs exist. In cattle and horses, affected animals may be found dead at pasture when no prior clinical signs have been observed. Be aware of the horse that suddenly becomes less active and constantly wants to lie down. When you urge the animal to stand, it trembles all over, walks with short strides, and immediately starts to lie down again. If it lies in sternal posture, it will rest its chin on the ground to support its head. You may mistake this tendency to lie down for an onset of colic, and the more you make this horse stand, the more it will be stressed, and severe diffuse sweating and an elevated pulse rate will follow. Cattle with diffuse NMD such as botulism may lie in sternal recumbency with their neck flexed to one side and their head resting on their thorax. This is the classic posture of milk fever, which is a metabolic muscular disorder caused by hypocalcemia. Cattle with acute signs of hypokalemic myopathy will assume the same posture. See the case example 5-2 discussion later. It is presumed that they assume this posture because of the weight of the head and neck, which they cannot support in a normal extended position. The GSE components of cranial nerves are usually affected in botulism, resulting in paresis of the facial muscles and the muscles of prehension and swallowing. Affected foals that try to nurse typically dribble milk from their nose. Eyelid and tongue paresis and dysphagia are common. Loss of tail tone is also seen in large animals. Dogs usually remain ambulatory but lose tone and spinal reflexes and often exhibit dysphagia. It is important to recognize that when these animals are able to walk with this diffuse LMN disorder, they display short strides but are not ataxic. Video 5-2 shows a 5-year-old castrated male thoroughbred with a presumptive clinical diagnosis of botulism. Clinical signs of inactivity, a shortened stride, and frequent periods of lying down in the stall were first observed 3 days before this video was made. Note the slightly lowered neck, the shifting of its weight between its limbs, the trembling, the difficult prehension with dropping of its feed, the paretic tongue, the hypotonic anus, and the shortened strides with no indication of ataxia. Note that when he was placed in a stall, he immediately lay down. This horse received specific type B antitoxin on the 2nd day of clinical signs, but by the 5th day was unable to stand and died the next day. We thank Dr. Caroline Hahn and Dr. Ian Mayhew of the University of Edinburgh for sharing this video with us. In the case example of the red-bone coonhound, it would be unusual to have such an acute diffuse LMN tetraplegia in a dog from botulism, and certainly without greater evidence of cranial nerve involvement. Myasthenia gravis, grave muscle weakness, is a disorder at the neuromuscular junction. The two forms are 1. Congenital and 2. Acquired. Congenital forms are observed primarily in puppies, and most represent a developmental disorder of the acetylcholine receptor that may be inherited. The acquired form is more common. It occurs in adults, although cases have been diagnosed as early as 3 months of age, and it is an autoimmune disease. The basis for this autoimmune disorder is unknown. It is hypothesized that a spontaneous disorder occurs in the immune system that results in the production of antibodies against the nicotinic acetylcholine receptor. The trigger for this is unknown. A genetic predisposition may be involved, but its nature remains undefined. Although the disease is diagnosed more commonly in larger breeds, especially the golden retriever, German shepherd dog, Akita, and German shorthair pointer, any breed and mixed breeds may be affected. A familial basis has been proposed for the Newfoundland and Great Dane breeds. These antibodies bind to the acetylcholine receptor and prevent the attachment of the acetylcholine released from the axonal terminal in response to the neuronal impulse. Once the antibody is bound to the acetylcholine receptor, the entire unit is internalized into the muscle and is no longer available. It must be replaced by the formation of a new receptor. The large abundance of receptors provides a safety factor because many are spared from this antibody binding. This is the basis for the classic signs of exercise-induced fatigue, which is an episodic paresis associated with exertion. Signs of paresis are present only when there are inadequate numbers of acetylcholine receptors to bind with the acetylcholine that is released from the axonal terminal. 3 clinical syndromes are observed in dogs. 1. Generalized. 2. Focal. And 3. Fulminating. In the generalized syndrome, if a patient is presented to you after a period of rest and relaxation, your examination may be normal. If you vigorously exercise this animal for a variable period, usually less than 10 minutes, the paresis will first be seen in the pelvic limbs, with the development of a short stride and a crouched posture. Thoracic limb paresis usually follows, accompanied by a flexed neck posture, and collapse may occur. Even when the animal has collapsed, the spinal reflexes are usually preserved. This is often accompanied by some dyspnea, drooling, and eyelid and lip paresis. If the patient is placed in a cage to rest for 30 to 60 minutes, the signs of paresis disappear, and the patient comes out of the cage normal. But after walking briskly for just a few minutes, the paresis usually recurs. Be aware that this episodic feature is not a requirement for the diagnosis. Occasionally, the antibodies are able to bind nearly all of the receptors, causing a fulminating form of myasthenia gravis, and the clinical clinical signs will be similar to those of the red-bone coonhound presented at the beginning of this discussion. An owner commonly observes that the dog is unable to keep its food down. From the description of this event, you usually can determine that this is regurgitation, not vomiting. It is the result of a megaesophagus that is commonly present in dogs that have diffuse paresis caused by myasthenia gravis. Remember that most of the esophageal muscle in dogs is striated voluntary muscle innervated by GSE neurons, and these muscle cells have acetylcholine receptors identical to those in skeletal muscle. It is paramount that the clinician distinguish regurgitation from vomiting in these patients by obtaining appropriate history at the time the patient is presented. Vomiting has an active abdominal component, whereas regurgitation does not. Aspiration pneumonia commonly accompanies this regurgitation and may be life-threatening. Focal forms of myasthenia gravis occur in muscles innervated by cranial nerves. They may occur in combination or as isolated events. The most common focal form is limited to the esophagus and causes a megaesophagus and regurgitation, especially in older dogs. Myasthenia gravis may be limited to the laryngeal muscles, causing dyspnea, to the pharyngeal muscles, causing dysphagia, and to the facial muscles, causing weak eyelids and lips. In humans, myasthenia gravis may be limited to the extraocular muscles, causing diplopia, a diagnosis that is difficult to make in animal patients. Acquired myasthenia gravis is much less common in cats than in dogs. The Abyssinian and Somali breeds have a high incidence. Myasthenic cats tend to exhibit the episodic characteristic much less commonly. Cats are usually difficult to exercise in a hospital environment. Sometimes, their refusal to walk poses difficulties in evaluating their gait in the case of a neurologic disorder. Unfortunately, most cats are not leash trained. A cat commonly carries its head and neck in a flexed position when it has a neuromuscular disorder such as myasthenia gravis. Megaesophagus is less common in cats with acquired myasthenia gravis, and the focal forms are less commonly diagnosed. Only the proximal esophagus has striated muscle in the cat, which likely explains the less frequently observed megaesophagus and regurgitation in cases of myasthenia gravis compared with the dog. In the congenital form of myasthenia gravis, clinical signs are usually seen by 3 to 8 weeks of age in multiple puppies in a litter, and these signs commonly progress as the puppies grow and may result in their inability to walk. This form usually involves an abnormality in the development of the acetylcholine receptor, when its abnormal structure prevents the binding with acetylcholine, or when insufficient numbers of receptors have developed. Strong evidence suggests that this disease is inherited as an autosomal recessive gene in the smooth fox terrier, the Parson, Jack, Russell Terrier, and the Gamel Dance Concerhound. It has been reported in the Springer Spaniel and the miniature smooth dachshund, and I have seen it in the Samoyed breed. In a few instances, the affected young animal may spontaneously recover. The inherited disorder in the Gamel Dance Concerhound is presynaptic and involves an abnormality in the release of sufficient acetylcholine from the axonal terminal. Megaesophagus has been reported only in the smooth fox terrier. Congenital myasthenia gravis is rare in cats. A congenital form of myasthenia gravis has been recognized in Brahman calves that exhibit a muscle paresis at birth or within the first month of life. Ultimately, in a few months, this is lethal for the calf. This is inherited as an autosomal recessive gene that codes for one of the subunits of the acetylcholine receptor. A polymerase chain reaction, PCR-based DNA, deoxyribonucleic acid, test performed on blood or semen will confirm the diagnosis in affected calves and detect the clinically normal carrier animals. Be aware that a neonatal myasthenia gravis occurs in human children born to mothers who have acquired myasthenia gravis, presumably from the passage of antibodies across the placenta. The same can occur in puppies after ingestion of colostral antibodies. We are not aware of any published report of this in domestic animals. Diagnosis. The most common ancillary procedure used to diagnose myasthenia gravis is an intravenous injection of an ultra-short-acting antitulinsterase, edrophonium chloride, tenserlin. By blocking the degrading enzyme of acetylcholine, it allows more opportunity for the acetylcholine to be available to those receptors that are not bound to antibody. Exercise your patient first so that the LMN paresis is obvious. Inject the edrophonium intravenously at 0.1 to 0.2 milligrams per kilogram, mg/kg, in cats, 0.25 to 0.5 mg. You should expect any response to occur in just a few seconds, but it will be short-lived and last only 2 to 3 minutes because the drug is rapidly metabolized. This test is reliable for most cases, but a few dogs with the episodic form will not respond, and a few dogs with other LMN disorders will show some response. Most dogs with the fulminating form of myasthenia gravis will not respond because most of their acetylcholine receptors are bound with antibody. Some congenital forms will not respond. Toxicity to this drug is uncommon but may occur in the normal dog or in an overdosed patient because of the overstimulation of the acetylcholine receptor, which causes a depolarizing blockade. You should have atropine available to treat this possibility of toxicity. We, e.g., MK, often pre-treat patients with atropine prior to the injection of edrophonium. In the acquired forms of myasthenia gravis, usually circulating antibodies against the acetylcholine receptor present, which may be determined by laboratory analysis. In our experience, these antibody levels are generally lowest in the patients with focal signs and highest in the fulminating cases. However, no definitive evidence exists in scientific studies to support this relationship. Indeed, some mild focal forms of this disease have the highest antibody levels. False negatives may occur and have no clear explanation. This ancillary procedure is of no use in the congenital forms. However, the total volume of acetylcholine receptor may be assayed in the laboratory from a sample of an external intercostal muscle. This may help confirm the diagnosis of congenital myasthenia gravis when it involves a deficiency of acetylcholine receptor formation. All patients should have radiography of the thorax to determine whether megaesophagus is present, to look for the presence of aspiration pneumonia, which is common with a megaesophagus and is life-threatening, and to look for a thymic mass. The latter is seen in less than 5% of dogs and in about 25% of cats with acquired myasthenia gravis. It is thought that thymic hyperplasia or neoplasia may play a role in the production of the antibodies against the acetylcholine receptor. In humans, the recovery from myasthenia gravis is enhanced by the removal of this thymic mass. It is believed that the antibodies produced against the thymic mass cells are similar to those produced for the acetylcholine receptor. Hypothyroidism in dogs with acquired myasthenia gravis has a significant incidence, which justifies evaluating the thyroid function in these patients. If electrodiagnostic equipment is available, the diagnosis may be supported by repetitive stimulation of a nerve and observation of the immediate decrement in the response of the muscle. This decrement will be reduced or will resolve after the intravenous administration of edrophonium, tenserlin. Single fiber electromyography is a more specific determination but requires specialized needles and operator expertise. These tests require generalized anesthesia, which may be contraindicated in certain patients. The following videos show examples of myasthenia gravis. Video 5-3 shows Bright, a 5-year-old spayed female Labrador retriever with a history of 10 weeks of occasional episodes of paresis associated with exercise. The frequency had increased in the past week, along with occasional regurgitation. This dog had been resting in her cage for a few hours before the video was made. She walked through the hospital and continued outdoors with a normal gait but then became paralytic, as seen on the video. Note the progression of the paresis as she is walked. Her response to intravenous edrophonium erythrophonium, and the recurrence of the paresis at the end of the video. Radiograph showed a megaesophagus. Video 5-4 shows Sailor, a 7-year-old castrated male standard poodle with a 1-week history of episodes of pelvic limb paresis. Note the response to intravenous erythrophonium. Video 5-5 shows Ruddy. Video 5-5 shows Ruddy, an 8-year-old male Absinian with 1 month of progressive inactivity, inability to climb stairs or jump up onto the bed, and less vocal than usual. Note the flexed neck posture, the reluctance to walk, the slight facial paresis, and the response to intravenous erythrophonium. Video 5-6 shows Maya, a 5-week-old female English Springer Spaniel. She was one in a litter of 6 that appeared to be less active when the others began to walk, and she had difficulty walking. She would tremor when she tried to interact with her littermates. Note the crouched posture, flexed neck, and short strides. She showed some response to intravenous etrophonium and was diagnosed as a presumptive congenital myasthenic. She improved on oral treatment with pyridostigmine, which is a long-term anticholinesterase drug. This can be seen at the end of the video, which was made about 1 week after the start of therapy. By 16 weeks, she was normal and was weaned off the drug. Presumably, this is an example of an insufficient development of acetylcholine receptors. Video 5-7 shows a 2-week-old Brahmin calf that had exhibited diffuse signs of NMD since birth. The calf spent most of its time lying down, was slow to get up, and walked with short strides. Note the response to intravenous etrophonium. This is a calf with an inherited acetylcholine receptor abnormality, and it will not recover. We thank Dr. Peter Thompson at the University of Pretoria for providing this video. Video 5-8 shows a 1-week-old female Holstein that since birth had been inactive, had short strides, and had spent most of her time lying down. Note her response to intravenous etrophonium. She was normal by 6 weeks of age, which suggests that a delay occurred in the formation of acetylcholine receptors. Palliative treatment for acquired myasthenia gravis may provide a constant source of anticholinesterase by oral administration, or treatment may be directed at the antibody production itself with the use of immunosuppressant drugs. Pyridostigmine bromide, methanol, is the most commonly used oral anticholinesterase. In dogs, the dosage is 0.5 to 3.0 mg/kg every 8 to 12 hours. Start with a low dose and slowly increased amounts are used until satisfactory improvement in the clinical signs occurs without signs of toxicity. In cats, the dosage is 0.25 mg/kg every 8 to 12 hours. If regurgitation interferes with this oral administration, either administer it via gastrostomy tube or use an intramuscular injection of neostigmine, prostigmine, until the oral route is accepted. Be aware that an overdose of anticholinesterase will cause paralysis from excessive depolarization of the muscle. This is the nicotinic effect of the overdose. It will sometimes be accompanied by the muscarinic effect, which includes excessive salivation, vomiting, diarrhea, miosis, and bradycardia. This cholinergic crisis should be treated with atropine. To distinguish an overdose from an inadequate dose of the medication, an etrophonium test should be done carefully. Corticosteroids and azathioprine have been used successfully as immunosuppressants. In dogs, prednisone should be started started at a low dose of 0.5 mg/kg every 12 hours to prevent the initial exacerbation of the neuromuscular signs. Gradually increase the dose to immunosuppressive levels over 1 to 2 weeks. Try to attain an alternate day schedule that will control the disorder. Cats are treated with 1 to 4 mg/kg every 12 hours. The dosage of azathioprine in dogs is 1 mg/kg every 12 hours. Recently, cyclosporin has been used for the treatment of myasthenia gravis. The goal of the treatment is essentially to buy time for the spontaneous resolution of the immune disorder and the replacement of the internalized receptors. After a few months of successful therapy, the drug should be slowly withdrawn. When the serum level of acetylcholine antibodies decreases to an undetectable level, treatment may be stopped. Occasionally, a recurrence will occur and require more treatment. This spontaneous recovery suggests that the immune system disorder is short-lived. The megaesophagus may persist despite therapy, and postprandial regurgitation will be a constant threat for aspiration pneumonia. The latter must be treated aggressively. It is important to feed these dogs when they are the strongest following treatment. Feeding moist food or slurry in small portions more frequently and from an elevated position may be helpful. Be aware that the long-term treatment of myasthenia gravis may be frustrating and unsuccessful. Many patients will develop aspiration pneumonia and require multiple hospitalizations. Therefore, owners must be warned about this possibility and the associated costs. Some congenital forms of myasthenia gravis improve by antitcholinesterase therapy. Occasionally, puppies outgrow the clinical signs that were presumed to be caused by an insufficient development of acetylcholine receptors. In the case of Coleman, the recombinant red-bone coonhound, see earlier discussion, only the fulminating form of myasthenia gravis would be a consideration. This degree of severe atonia and areflexia would be less likely in most cases of myasthenia gravis. A negative response to edrophonium would not eliminate this diagnosis. Determination of serum antibodies to acetylcholine receptors would be necessary to support this diagnosis. This red-bone coonhound did not respond to intravenous edrophonium and had no serum antibodies for acetylcholine receptors. Tick paralysis. For tick paralysis to occur, it is essential that the animal be exposed to a species of tick that has in its saliva a neurotoxin that is injected into the animal when the tick bites to extract blood from the animal. We are all taught to obtain a travel history for our patients because it may be important in diagnosing disorders that are not indigenous to our practice areas. Tick paralysis is an excellent example of this because a dog may acquire a tick attachment on the mid-Atlantic coast and travel to a state that has no toxin-carrying ticks before the dog shows any signs of paresis. The only diagnosis that I ever made of tick paralysis in a patient at the College of Veterinary Medicine at Cornell University was in a dog from Ithaca, New York, which had spent the previous week on the shores of North Carolina. The few species of ticks that inhabit the Ithaca area do not carry the necessary neurotoxin. I made this diagnosis in a young Labrador Retriever that had traveled over one weekend from Southern Virginia to New York City and developed the clinical signs of tick paralysis a few days later. On the other hand, I have had the opportunity, while practicing in Georgia, to make this diagnosis in many dogs. In North America, tick paralysis is most common in dogs and children, but all species of domestic animals and some species of birds are also susceptible to this neurotoxin. In the United States, the common wood ticks, Dermacentor variabilis, and Dermacentor andersoni are incriminated most often. Clinical signs may occur after having been bitten by a single female tick. The neurotoxin enters the circulation and gains access to the neuromuscular junctions where the toxin interferes with the function of calcium and the release of acetylcholine from the axonal terminal. Clinical signs occur 5 to 9 days after the tick infestation, with a rapid onset of LM and paresis starting in the pelvic limbs and spreading to the thoracic limbs. Dogs may become recumbent in 24 to 72 hours. Spinal reflexes are depressed or absent. Nociception is normal, and hyperesthesia is absent. Cranial nerve LMN signs are uncommon except for severe cases. Megaesophagus is uncommon. Death may occur as the result of respiratory paralysis in 1 to 5 days. Diagnosis is based on a history of possible exposure to toxin-bearing ticks and a careful search of the affected animal for a tick. If the history and signs are compatible with this diagnosis and the offending tick cannot be found, it is worth giving the patient an insecticide dip to kill any hidden ticks. Removal of the tick will be followed by improvement in strength in several hours and recovery in 24 to 72 hours. I examined one chow chow crossbreed with diffuse LMN tetraplegia that had a history of walking in the woods. I bathed this dog at 5 p.m., and it was walking the next morning and was normal in 2 days. In general, we recommend tick baths in all dogs with acute diffuse neuromuscular signs regardless of any history of tick exposure because a tick bath is easily performed, is inexpensive, and may be life-saving. In eastern Australia, the neurotoxin secreted by the species of tick Ixodes hilociclus produces an extremely severe, rapidly progressive paralysis that is commonly lethal. Death may occur rapidly in all species, including humans, sometimes even after removal of the offending tick. Video 5-9 shows Lola, a 6-month-old female Maltese with sudden onset of a stumbling gait that progressed to recumbency in 24 hours. Note the hypotonia and areflexia but intact nociception, as indicated by the head movements. The voice was not audible. Facial paresis and jaw hypotonia were seen. A veterinary student found a tick and removed it. The last part of the video shows Lola 24 hours after removal of the tick. The red-bone coonhound under discussion was from upstate New York, where no ticks that secrete a neurotoxin exist, and this dog had no history of travel from the farm where he was housed. No ticks were found on this dog, and no insecticide dip was considered necessary. Polymyositis. A generalized polymyositis is most commonly the result of an autoimmune disorder associated with antibodies circulating against striated skeletal muscle in dogs. A number of infectious agents such as Toxoplasma gondii, Neospora caninum, and Leptospira ictera hemorrhagiae may cause myositis. They usually affect body systems other than the muscle and are less often generalized. Autoimmune myositis may be focal and limited to the muscles of mastication, the extraocular muscles, or the muscles of the pharynx and esophagus, or may be generalized. Masticatory myositis is the focal form most commonly diagnosed in dogs. Any breed is susceptible, but the incidence is high in German Shepherd dogs. Both acute and chronic forms exist. In the acute form, the masticatory muscles are swollen and very painful. The clinician should not try to open the animal's mouth because this causes pain to the patient. The dog's reluctance to open the mouth prevents it from eating. The swelling is so severe that the eyes may protrude from the orbits. Fever and swollen palatine tonsils and mandibular lymph nodes may be present. Biopsy of the swollen muscles will reveal a diffuse necrotizing inflammation with hemorrhage and edema. Inflammatory cells include macrophages, plasma cells, lymphocytes, ococyanally neutrophils, and sometimes eosinophils. Serum muscle enzymes usually are significantly elevated, and circulating antibodies to the type 2M muscle fibers that predominate in these muscles are present. Magnetic resonance imaging, MRI, has been used to diagnose the acute form of masticatory muscle myositis. Treatment with immunosuppressant drugs alleviates the acute clinical signs, but recurrences may occur. In the chronic phase, muscle atrophy may be severe, and the fibrosis that occurs in the muscle may in time cause mechanical inability to open the mouth. Some dogs only have a chronic myositis limited to the masticatory muscles, but it results in the same severe atrophy and inability to open the mouth. Do not try to force the jaw to open under anesthesia. You will fracture the mandible. If immunosuppressant drug therapy is ineffective, consider surgically cutting the attachments of the temporal and masseter muscles to the ramus of the mandible. No neurologic disorder other than tetanus causes the inability to open the jaw. Only a fibrosing muscle disorder causes this problem. The term trismus refers to the excessive uncontrolled contraction of the masticatory muscles that is present in tetanus. It is not an appropriate term for the fibrosing stage of chronic myositis, which is a mechanical resistance. I have used corticosteroids, azathioprine, and oral cyclosporine to treat these patients and have seen varying responses. Other focal forms of presumptive autoimmune myositis have been reported in young adult dogs. It may involve the extraocular muscles, causing a prominent exophthalmos, the laryngeal muscles, causing dyspnea, or the pharyngeal muscles, causing dysphagia. Generalized autoimmune polymyositis may mimic the LMN signs seen in a dog that has polyradiculoneuroitis but is ambulatory. It is rare for this muscle disorder to cause recumbency and tetraplegia. In the acute phase, the affected muscles may be swollen, and discomfort upon palpation will be evident. Usually, the spinal nerve reflexes will be preserved. In the chronic phase, muscle atrophy will be significant. Be aware that the clinical signs of paresis in these dogs may worsen with exercise and that sometimes they will show a moderate response to an intravenous injection of edrophonium. Involvement of the esophagus will result in megaesophagus and regurgitation. As a rule, the diagnosis is supported by a marked elevation of the serum enzymes. A biopsy of an affected muscle that reveals necrosis of muscle cells, with macrophages and prominent lymphoplasmacytic interstitial inflammation, confirms the diagnosis. Serum assay often detects circulating antibodies against skeletal muscle antigens. EMG studies are nonspecific in that the abnormalities seen do not clearly distinguish a neuronal disorder from a muscle disorder. Observing normal nerve conduction studies may be helpful. MRI has been used to diagnose focal forms of myositis, including the form that affects the extraocular muscles. Occasionally, dogs with immune-mediated polymyositis also have hypothyroidism caused by the same kind of inflammation that is affecting their thyroid glands. Maybe this suggests that a common factor triggers these two autoimmune disorders. 7. It is hoped that this may be determined as our ability to study the canine genome progresses. Polymyositis may be observed as a paraneoplastic syndrome, often associated with lymphoma. In some dogs, polymyositis may precede the development of a neoplasm. Generalized polymyositis is uncommon in cats. A dermatomyositis occurs primarily in collies and Shetland sheepdogs. Treatment of polymyositis with immunosuppressant drugs should be initiated and continued until serum enzyme levels return to normal. Recurrences may occur, and alternate day therapy with corticosteroids may be necessary for prolonged therapy. Video 5-10 shows a 4-year-old male Labrador Retriever that had a slowly progressing gait disorder for 3 to 4 weeks. He became worse with exercise, and he never had normal periods. Note the crouched posture, the short strides without any ataxia, the decreased range of jaw movement, and the diffuse moderate muscle atrophy. All of the serum muscle enzymes were elevated. Creatine kinase, CK, 3033 units L, normal, 241, aspartate aminotransferase, AST, 252 units L, normal, 52, alanine aminotransferase, ALT, 256 units L, normal, 99. The muscle biopsy showed an extensive non-suppurative inflammation associated with muscle necrosis. The tetraplegic red-bone coonhound in this case example is an unlikely candidate for acute polymyositis because of the severity of his flaccid paralysis with atonia and areflexia. His serum enzyme levels were only moderately elevated, which would be expected in a recumbent patient. Other differential diagnoses. Other considerations for this recumbent red-bone coonhound with the LMN tetraplegia include snake envenomation and possibly organophosphate toxicity. Snake envenomation obviously requires exposure of the patient to the bite of a snake whose venom is toxic. The two most common species of snakes whose venom causes a postsynaptic blockade of the neuromuscular junction are the coral snakes found in the southeastern states and the North American rattlesnake in the southern and southwestern states. The onset of clinical signs of a rapidly progressive LMN tetraparesis varies from 30 minutes to a few hours but less than 24 hours, so little time is available for travel to a state that is free of the offending snake. When recumbent, spinal nerve reflexes are lost, and significant paresis of the muscles innervated by cranial nerve GSE neurons occurs. Death results from respiratory muscle paralysis. This can be prevented by immediate administration of specific antivenom. Less severely affected animals may recover spontaneously in 7 to 10 days. The observation of hemolysis and hemoglobinuria helps support this diagnosis when the snake bite is not observed. Swelling and erythema of the skin at the site of the bite wound may be observed. However, in some dogs, no external wounds may be seen. Organophosphate toxicity may occur in different forms. The form that is a possible consideration in this tetraplegic dog is one in which the toxin causes a blockade of the acetylcholine receptor. Chlorpyrifos and phenthionine are acetylcholinesterase inhibitors. The resultant accumulation of acetylcholine will eventually cause a blockade at the receptor and produce LMN paralysis. Clinical signs are usually observed within minutes to hours of the exposure. Diagnosis is supported by a history of exposure and detection of decreased levels of cholinesterase in the blood. Treatment should include atropine for the muscarinic signs and 2-PAM, perlidoxime chloride, for the nicotinic signs. In some toxicities, diphenhydramine, Benadryl, may help block the action of the toxin. Coleman, the red-bone coonhound in this case example, had no possibility of exposure to a snake toxin and no history of exposure to any organophosphate. The severe degree of flaccid paralysis would be extreme for the latter diagnosis, especially with the absence of any muscarinic signs. It was concluded that the most presumptive clinical diagnosis for Coleman was polyradiculoneuritis. Only supportive therapy was provided. Despite being bedded on a thick layer of blankets, skin ulcerations occurred, as can be seen at the end of the video when he had regained the ability to walk after 3 weeks of recumbency. These ulcerations rarely occur when the animal is kept on a waterbed. By 5 weeks, Coleman's gait was normal. Given the relatively rapid rate of recovery, it was presumed that the major lesions in Coleman involved the myelin rather than the axons in his nerves. The following videos show 3 additional examples of polyradiculoneuritis coonhound paralysis in dogs used for hunting raccoons. Video 5-11 shows Swamp Fox, a 6-year-old male red-bone coonhound crossbreed that was presented for examination 24 hours after the owner recognized that the dog was lame and his voice was altered. 1 week before this, Swamp Fox had been bitten in the ear by a raccoon. Note the severely lame gait affecting all 4 limbs, which has been cramping caused by a rapidly progressing diffuse neuromuscular disorder, not a musculoskeletal disease. Note his preference for sitting and reluctance to walk, which is very abnormal for an active working coonhound. The second portion of the video, which shows a dog inside the hospital, was made 24 hours after the outdoor portion of the video. Now the dog is recumbent because of flaccid tetraplegia. Spinal nerve reflexes are absent, but nociception is intact and exaggerated. Note the howling caused just by palpation of the thigh muscles. Normally, coonhounds are minimally affected by mild noxious stimuli. Note the flaccid paralysis of the trunk, neck, and limbs, but the preservation of function in the head muscles innervated by cranial nerves. Swamp Fox was able to eat and drink well but had to be held up to do so. The portion of the video with Swamp Fox in the cage under a blanket was made 24 hours after the second video. He died the next day because of respiratory failure and the severity of his polyradiculoneuroitis, which was confirmed at necropsy. Video 5. Video 5-12 is another case of polyradiculoneuroitis that caused a less severe recumbency. This is Blackjack, a 1.5-year-old male mixed breed retriever from a farm in New York State, where he is exposed to raccoons. Blackjack had experienced a 2-week history of progressive difficulty in walking that began in the pelvic limbs and progressed to the thoracic limbs by the start of the second week. He had been recumbent for 2 days. Note the presence of more strength in the trunk and neck than in the limbs. When encouraged to come out of his cage, he could stand and squirm toward the door using his axial muscles but had only feeble movements in his limbs with his appendicular muscles. The second time, 3 weeks after the first portion of the video was taken, he is shown coming out of his cage. The portion taken outdoors was recorded 1 week later. Blackjack made a full recovery. All of his muscle mass returned, and, with no further contact with raccoons, the polyradiculoneuroitis did not recur. Video 5-13 is an interesting and instructive video made by the owner of Woody on the owner's farm near Buffalo, New York, and sent to us for our use and teaching. This video is accompanied by audio. Woody, the 6-year-old male mixed breed dog, had been clinically affected for about 2 months at the time the video was made. The first indication of a problem was when Woody was slow to return to the owner while hunting. It was followed by the dog's inability to jump into the owner's truck. The pelvic limbs were initially the most seriously affected, and Woody became recumbent after about 3 days of rapidly progressive paresis. The flaccid tetraplegia involved all of the muscles of the limbs, trunk, and neck but spared the head muscles innervated by cranial nerves. About 2 weeks before this video was made, the owner noticed some movement in Woody's head, neck, and tail. Woody had experienced a similar clinical disorder when he was 3 years old. It was 3 months before he had completely recovered. One addendum is needed here because this discussion of LMN tetraplegia involves only adult dogs. Dr. John Cummings and I studied 4 puppies in a litter of 8 Labrador retrievers that at 6 weeks of age developed LMN paraparesis. In a few days, it had progressed to LMN tetraplegia, with prehension difficulties and dysphagia, followed by death. These puppies all had a severe diffuse polyradiculoneuroitis caused by incandidum. The young age is critical here because this organism usually affects only spinal nerve roots in puppies under 12 weeks of age and usually is limited to the lumbosacral roots. See case example 5-11. This study emphasizes the importance of an autopsy. The diagnosis was not suspected during our clinical study of these puppies, and it is critical knowledge for breeders so that they can prevent future occurrences. I have also studied similar cases of puppies with tetraparesis that progressed to tetraplegia caused by incandidum. Some of the affected animals also had had evidence of cardiac disease and had autopsy. Organisms were found in heart muscle. The combination of cardiac disease and LMN tetraplegia in puppies may help diagnose infection with Encaninum, NMD tetraparesis. Dog signalment. 2-year-old male German Shepherd dog. Cosmos chief complaint. Gait abnormality history. 2 days of rapidly progressive difficulty in walking, especially with the pelvic limbs examination. Video 5-14 shows the rapid, short-strided gait in the pelvic limbs when he was assisted. Mild support loss in the thoracic limbs was more evident when he was made to hop. Muscle tone was normal. Spinal nerve reflexes were mildly depressed. Nociception was normal. Cranial nerves were normal. Anatomic diagnosis. Diffuse neuromuscular disease, worse in the pelvic limbs. Differential diagnosis. The same as for the dog in case example 5-1 polyradiculoneuroitis. The dog had experienced no known exposure to raccoons, but such exposure could not be totally denied. The cerebrospinal fluid, CSF, contained 4 leukocytes per cubic millimeter, MM3, and 40 milligrams protein per deciliter, DL, normal, 30. This albumin-acidologic dissociation is supportive of the diagnosis. Botulism. No known exposure was reported. The clinical signs were mild, and no cranial nerve signs were present. CSF should be normal in botulism patients. Myasthenia gravis. No history of improvement with rest and worsening with exercise was reported. The patient did not respond to intravenous etrophonium. CSF should be normal. Tick paralysis. This dog could have been exposed to ticks while on a camping trip in Virginia 1 week prior to the development of the neurologic signs. No ticks were found on the dog, and no improvement followed an insecticide bath. CSF should be normal. Polymyositis. Serum enzymes were normal. CSF should be normal. Hypokalemic myopathy. This is a rare cause of tetraparesis in the dog but is more commonly seen in cats and occasionally in cattle. It usually occurs in older cats that often have a chronic renal disorder with excessive renal loss of potassium or hypokalemia from hyperaldosteronism caused by a neoplasm of the adrenal cortex. Decreased dietary intake may contribute to this disorder. It must be ensured that the potassium content of the cat's diet is adequate. The onset of paresis is usually acute, with a stiff, short-strided gait, reluctance to walk, and flexion of the head and neck. The excessive neck flexion may be the only prominent clinical sign in some cats. Spinal nerve reflexes and postural reactions are normal. Serum potassium levels are low and serum muscle enzymes are elevated. An inherited hypokalemic myopathy has been recognized in Burmese cats that is observed clinically most often with onset in 2 to 6-month-old Burmese kittens. Affected cats exhibit episodes of muscle paresis that may be diffuse, causing a crouched, short-strided gait, or localized to the cervical and proximal thoracic limb muscles. The latter presents flexion of the neck and a prominent dorsal projection of the scapulae when the thoracic limbs are bearing weight. Discomfort may be evident when the affected muscles are palpated. Clinical signs may be precipitated by stress or exercise, are usually transient, and may be avoided by means of dietary supplementation. The hypokalemia results from an excessive loss through the kidneys. Genetic studies have identified a mutation in the WNK4 gene on chromosome E1, which is inherited as an autosomal recessive trait. A genetic test has been developed to identify this gene mutation. This disorder has been referred to as feline hypokalemic periodic paralysis or Burmese hypokalemic periodic polymyopathy. Affected cats have been identified in the United Kingdom, New Zealand, Australia, and the Netherlands. Hypokalemic myopathy in cattle is an iatrogenic disorder associated with the use of the mineralocorticoid drug isoflupridone, 9-fluoroprednisolone acetate, for the treatment of ketosis or COS. Cranial mastitis, 123 with the sudden loss of potassium through urine. These cattle are usually found recumbent, with no muscle tone, with their neck flexed laterally, and with their head resting on their thorax, similar to the posture of a cow with milk fever, which is associated with her hypocalcemic myopathy, figure 5-13. These cattle may be found dead. Recumbent cattle treated for hypokalemia have a guarded prognosis. To make the correct diagnosis, it is important to recognize that in cattle, the recumbent posture, with the head and neck resting on the side of the thorax, is a clinical sign of a neuromuscular disorder, as is the ventral flexion of the head and neck in a standing animal. The most presumptive clinical diagnosis for the German Shepherd dog in this case example was polyradiculoneuroitis. Only supportive care was provided, and the dog began to improve in about 2 weeks. The last portion of the video shows improved walking at that time. NMD tetraparesis, dog signalment, 5-month-old male Labrador Retriever, Nemo chief complaint, poor growth, progressive paresis, exercise-induced collapse history. When this dog was purchased at 3 months of age, he was smaller than his litter mates and was less playful. He has progressively become less active and he becomes fatigued with exercise, which recently resulted in his collapse and the necessity of his being carried home from a long hike. His growth has been slow and his muscle development poor. Examination. Video 5-15 shows the short strides, the arched back, the lowered head and neck, the diffuse muscle atrophy, and a lack of patellar reflexes in this Labrador Retriever. Anatomic diagnosis. Diffuse neuromuscular disease. Differential diagnosis. The differential diagnosis would include the 7 major disorders described in the first 2 case examples. However, the age of onset and the very slow and insidious progress sign of the clinical signs would be unusual for any of these 7 disorders. In any consideration of a differential diagnosis, always be sure to ask yourself whether any disorder that is unique to this breed could produce these signs. In this case, 2 inherited muscle disorders should be considered. The most common is a polymyopathy that is inherited as an autosomal recessive gene disorder. The less common is a muscular dystrophy associated with a deficiency of a cytoskeletal glycoprotein, dystrophin, which is inherited as a sex-linked recessive gene. This is described in case example 5-4. Synchronic clear, type 2 deficiency, autosomal recessive polymyopathy in Labrador Retrievers. Nemo's clinical signs are typical of a polymyopathy inherited as an autosomal recessive gene disorder. It was originally studied and published by Jack Kramer of Washington State University in 1976 as an autosomal recessive inherited deficiency of type 2 muscle fibers. 87. 88. The disorder has now been recognized in Labrador Retrievers in many countries throughout the world. 8,299,104 more recently. It has been described as an autosomal recessive centronuclear myopathy based on the prominence of abnormal centraliza, Cheyenne of myonuclei. Light and electron microscopic studies have shown progressive changes in internal tubuloarticular and sarcolemmal membranes, triads, and mitochondria. A mutation in the PTPLA gene that is associated with this myopathy has been identified. 141. This myopathy has also been described as a muscular dystrophy. This is inappropriate because the muscle lesion is not a muscular dystrophy, in which the histologic examination of affected muscle should show both degeneration and regeneration of muscle cells. The video of Nemo, the dog presented in this case example, shows the classic clinical signs of this synchronically polymyopathy. The depressed or absent patellar reflex is a common clinical sign and may reflect involvement of the small striated intrafusal muscle cells in neuromuscular spindles. Ancillary studies supported this diagnosis. No response to an intravenous injection of erythrophonium was seen. Serum muscle enzyme levels were normal. Occasionally, they are slightly elevated in this muscle disorder. CSF was normal. Electromyography, EMG, revealed a few denervation potentials and a few bursts of complex repetitive discharges. Nerve conduction times were normal. Such an electrodiagnostic study is quite typical of this disorder. The nerve biopsy was normal. The muscle biopsy showed a variation in muscle fiber size, a depletion of type 2 muscle fibers, and a few cells with centrally positioned nuclei but no necrosis of muscle cells. This synchronically Labrador Retriever polymyopathy has a good prognosis for life because it is self-limiting. It rarely progresses beyond more than 9 or 10 months and rarely causes recumbency. Owners learn to limit the amount of exercise to avoid having to carry the dog home. Obviously, such a dog and its parent should not be used for breeding. Nemo's clinical signs had remained essentially unchanged when he was last examined at 10 years of age. I studied a 7-month-old Labrador Retriever that lived with the disease for 12 years before being euthanized for unrelated kidney failure, and NMD tetraparesis, dog signalment, 7-month-old male Labrador Retriever, Jake chief complaint, abnormal gait and abnormal prehension history. This dog was the smallest of the litter and did not grow well. By 9 to 10 weeks of age, he was less active than his litter mates, lay down much of the time, rapidly fatigued with exercise, drooled constantly, and was a very sloppy eater. These clinical signs have slowly progressed over the subsequent few months. Examination. Video 5-16 shows Jake's examination. Anatomic diagnosis. Diffuse neuromuscular disease differential diagnosis. This is the same as that described in case example 5-3. The major difference between Nemo's case example 5-3 and Jake is the constant drooling exhibited by Jake and the decreased range of motion on trying to open the mouth. The diffuse muscle atrophy, the short strided gait in all 4 limbs, the arched back, and the lowered head and neck position are similar. However, Jake had normal patellar reflexes, whereas these were absent in Nemo. Dystrophinopathy, a sex-linked recessive muscular dystrophy. These clinical signs exhibited by Jake are typical of a mild presentation of the sex-linked inherited muscular dystrophy caused by a deficiency of dystrophin. 8. In addition to the abnormal posture and gait, a very early clinical sign is the decrease in range of mouth opening associated with prehension difficulties and sialosis. As the disease progresses, the tongue and pharyngeal muscles begin to feel enlarged between the mandibles. Although diffuse atrophy of most axial and appendicular muscles occurs, some of the caudal thigh muscles will hypertrophy along with the diaphragm. To support the clinical diagnosis of muscular dystrophy with dystrophinopathy, an ancillary test that is extremely reliable is the determination of a marked elevation of serum muscle enzyme levels. In dystrophinopathy, muscle fiber necrosis is usually severe, which results in the marked elevation of the serum enzymes CK, AST, and ALT in Jake's serum. CK was 59,200 units Al, normal, 359, AST was 725 units Al, normal, 56, and ALT was 431 units Al, normal, 92. Muscle biopsy shows the extensive muscle cell necrosis, which is responsible for the high levels of circulating serum muscle enzymes. Figures 5-14 through 5-18. This necrosis is associated with large accumulations of macrophages macrophages, fibrosis, mineralization, and lipid accumulation in the presence of rows of proliferating satellite cells and regenerating muscle cells. Immunocytochemistry clearly shows the lack of dystrophin in the muscle cell membrane. This muscular dystrophy is inherited as a sex-linked recessive gene. Therefore, as a rule, only male dogs are clinically affected. This is a spontaneous mutation of a very large gene associated with the X chromosome that was first recognized in male golden retrievers. These golden retrievers have served as a reliable model for the similar human disorder referred to as Duchenne muscular dystrophy. Since its original recognition in golden retrievers, this dystrophinopathy has been found in many different breeds of dogs. The clinical signs vary considerably among affected dog breeds, according to the nature of the spontaneous mutation. See Figure 5-19 of a 5-month-old male Rottweiler with a severe form of dystrophinopathy. It is a rare disease in cats, in which diffuse hypertrophy of muscles severely limits the rate and range of motion. It may be lethal in young puppies. Severely affected dogs have limited lifespans and often develop complications associated with their cardiomyopathy. Video 5-17 shows the first two affected golden retrievers, Shadow and Goldie, that I studied in 1972. They came from a litter raised in Ithaca, New York. Video Video 5-18 shows a third dog, which came from Northwest Pennsylvania and was studied in 1982. Note the stiff, rolling movements of the limbs. This reflects both muscle fibrosis and a degree of myotonia in the affected muscles. Note the posture of the tarsus, the arching of the back, and the reduced range of motion of the temporomandibular joint. Compare Jake and these three golden retrievers with Stubby in Video 5-19. Stubby, a 10-month-old rat terrier, was presented at 7 months of age because of a stiff gait and dysphagia. Note the remarkably enlarged neck muscles at 10 and 14 months of age. This video was made during the clinical study of this dog by Dr. Ken Harkin at Kansas State University. Stubby had a CK level of 66,420 unit cell and had no dystrophin in his skeletal muscle cell membranes. These videos show some of the remarkable range of clinical signs that may occur with the various mutations of this dystrophin gene. As we are able to define these various mutations, we should be able to associate them with their respective phenotypes. Carrier females often have mildly elevated serum enzymes but rarely develop clinical signs. This relates to the volume of skeletal muscle cells that have the X chromosome with the mutated dystrophin gene. At the time these young male golden retrievers were studied in 1972, a similar clinical muscular dystrophy was being studied in young male Irish terriers in the Netherlands. Be aware of young dogs that are presented to you because of fatigue on exercising, inactivity, and slow growth. Any one or more of these clinical signs may reflect a muscular dystrophy related to a mutation in the genes responsible for the multiple components of the dystrophin glycoprotein complex. This cytoskeletal complex resides in the skeletal muscle cell membrane and is responsible for anchoring the actin myofilaments to the cell membrane and the adjacent basement membrane and extracellular matrix to support the cell during muscle contraction. A loss of any one of these components may result in muscle cell bone necrosis, a muscular dystrophy. Be persistent in your clinical study of these often quite subtle clinical signs. Muscle specimens may be submitted to Dr. Diane Shelton at the Comparative Neuromuscular Laboratory at the University of California at San Diego for immunocytochemistry to determine whether any abnormality exists in this dystrophin glycoprotein complex. Exercise-induced collapse in Labrador Retrievers. We thank Dr. Susan Merrick Taylor for her editing of this description and providing videos 5-22 and 5-23 for the website. The previous two case examples of polymyopathy in Labrador Retrievers are very different from a unique inherited disorder in Labrador Retrievers, which clinically affects adult dogs and causes collapse after vigorous exercise. Video 5-20 shows a 1-year-old male Labrador Retriever in Oregon, which had been exhibiting episodes of collapse for the past 2 months when exercised vigorously. The dog had been chasing the ball for about 10 minutes when the video was recorded. The owner stated that the same degree of exercise in the ocean surf never caused any fatigue in this dog. Video 5. Video 5-21 shows a 4-year-old male Labrador Retriever in Ohio being exercised and having a collapsing episode. Similar episodes had been occurring for at least 1 year. Video 5-22 shows a 2-year-old female Labrador Retriever at the end of a 10-minute standardized exercise protocol investigating this disorder at the University of Saskatchewan. All of these dogs showed signs typical for the disorder known as exercise-induced collapse, EIC, and recovered completely after about 15 minutes of rest. EIC episodes typically begin in juvenile or young adult, 7 months to 2 years, dogs when they are engaging in strenuous activity with a high level of excitement. Many cases are recognized when affected dogs commence their training as field trial dogs. After a brief period of vigorous exercise, 5 to 15 minutes, the affected dog starts to collapse in the pelvic limbs. The dog vigorously struggles to continue but rapidly loses its ability to stand and collapses, usually in sternal recumbency. At the time of collapse, affected dogs are hyperthermic, 107 degrees Fahrenheit to 108 degrees Fahrenheit, and pant excessively. However, hyperthermia of that magnitude is common in normal Labrador Retrievers after vigorous exercise. As the affected dog struggles to stand, it commonly exhibits some loss of balance and falls to one side. It never exhibits the typical quick, short strides of a dog with diffuse NMD. When the dog is collapsed, the pelvic limbs are flaccid and patellar reflexes are usually absent, but the withdrawal reflexes and nociception are normal. Dogs commonly get worse in the 3 to 5 minutes after exercise is halted, perhaps related to a progressive increase in their body temperature, and severe episodes of collapse sometimes progress to involve all 4 limbs. Video 5-23 shows a 1-year-old male Labrador retriever 5 minutes after completing a 10-minute standardized retrieving exercise protocol at the University of Saskatchewan. This dog had barely perceptible gait abnormalities at the end of exercise, but 5 minutes later, he had lost all ability to move his limbs. Patellar reflexes were absent but other reflexes remained normal. Dogs with the IC remain alert, and during an episode, they typically struggle to continue running until they are unable to do so. They never show any loss of cranial nerve function. No abnormal nystagmus has been observed. After a period of 10 to 20 minutes of rest, these dogs recover completely. The anatomic diagnosis is not clear in these dogs. Although a diffuse NMD was initially suspected, the character of the collapse and the loss of balance suggest a possible central disorder with a vestibular system component. All ancillary studies performed in animals at rest and during collapse have been normal. They include blood chemistries, metabolic studies, cardiac evaluation, MRI, heterophonium testing, acetylcholine receptor antibody assay, and muscle biopsies. Tests for malignant hyperthermia have all been negative. Autopsy of dogs that have died during an episode of collapse has revealed no abnormalities. Genetic studies have established that the IC is inherited as an autosomal recessive trait, and DNA analysis has identified a mutation in the dynamin-1 gene of affected dogs. Dynamin-1, DNM1, is a protein that plays a key role in repackaging neurotransmitters into synaptic vesicles for release in the brain and spinal cord. DNM1 is not required for neurotransmission during low-level neurologic stimulation, but when a heightened stimulus such as intense exercise, excitement, or hyperthermia creates an increased demand for release of CNS neurotransmitters, DNM1 becomes essential for sustained synaptic transmission. Dogs with DNM1-associated EIC, DEIC, presumably run out of prepackaged neurotransmitters and are susceptible to collapse in those conditions. Although dogs with 2 copies of the DNM1 mutation are susceptible to collapse, a few genetically affected dogs never exhibit collapse, perhaps because they never engage in strenuous activity with extreme excitement. DNA testing is the only way to know for certain whether a dog has DEIC, and this testing is available through the College of Veterinary Medicine at the University of Minnesota. Initially described in Labrador retrievers, DEIC has now been identified in curly-coated retrievers, Chesapeake Bay retrievers, German wire-haired pointers, Boykin spaniels, and Pembroke Welsh corgis. In time, selective breeding should reduce the incidence of this disorder. No specific treatment is available for DEIC, but the disorder is not progressive. Affected dogs generally lead healthy lives, as long as their participation in activities that trigger collapse is limited. Several dogs have died during severe episodes of collapse, so exercise should be stopped and attempts made to cool the affected dogs at the first hint of an abnormal gait. It has been observed that affected dogs are less likely to collapse when they are exercised in water or in cold weather. This DEIC has been under intense investigation by a team of veterinarians led by Dr. Susan Merritt Taylor, a Cornell College of Veterinary Medicine graduate, presently at the University of Saskatchewan in Canada. We look forward to future achievements by this group. Exercise-induced fatigue. This is an appropriate point in the text to consider the differential diagnosis for the clinical complaint of exercise-induced fatigue in a dog. On the basis of the presentation of this dog and the results of the examination, exercise-induced fatigue may be organized into 2 groups. 1. Dogs that are normal on examination, and 2. Those that are abnormal. For those that are normal and in which the paresis cannot be induced with exercise in your presence, it is useful to have the owner provide a video of the disorder so that you can determine whether the so-called exercise-induced fatigue is related to a diffuse NMD or another disorder such as cataplexy, syncope, focal seizure, or a movement disorder. When a dog is normal on your examination but the owner's description or the video clearly indicates diffuse NMD, the following disorders should be considered: myasthenia gravis, hypoglycemia, hyperkalemia, hypokalemia, muscular dystrophy, and, in Labrador retrievers, EIC. Appropriate ancillary tests may help differentiate these disorders. If the studies are unrewarding, be sure to include a thorough cardiovascular examination because the episodic paresis may be the only clinical sign of cardiac disease. Any decrease in cardiac output may result in peripheral hypoxia and paresis. In dogs that show evidence of NMD on your examination but are worsened by exercise, you should consider study of the following disorders: myasthenia gravis, polymyopathy, muscular dystrophy, polymyositis, hypoglycemia, hyperkalemia, and hypokalemia, motor neuron disease. Congenital. Refer to case examples 5-3 and 5-4, where it was emphasized that you should be sure to consider disorders related to the breed of the animal you are examining. Another group of disorders that must be considered for the anatomic diagnosis of diffuse NMD in the young animal is a motor neuron disease, MND, which is also referred to as spinal muscular atrophy. The primary lesion is an abiotrophy of GSE neurons in the spinal cord, ventral gray horn, and brainstem nuclei. By definition, an abiotrophy is a lack of a biologic substance in the cell that is necessary for the maintenance of the cell. This is an intrinsic cellular abnormality that is an inherited developmental defect. It results in the premature degeneration of that cell. In the nervous system, the parenchymal neurons normally live for the life of the animal and, with a few exceptions, cannot be replaced. In an abiotrophy, these cells degenerate prematurely at various times after their initial formation in the embryo. Usually, this degeneration does not occur until after birth, or at least, the clinical signs caused by this abiotrophy are often not recognized until a few weeks postnatally. Occasionally, this abiotrophy is delayed for many months or even a year or more. It depends on the population of neurons that are affected and the rate of the progression of the abiotrophy. Neuronal abiotrophy most commonly affects Purkinje neurons in the cerebellum and GSE neurons in the spinal cord and brainstem. Often, multiple neuronal systems are affected. Clinical signs usually reflect the loss of those neurons most important for the animal's ability to support weight and to generate a coordinated gait. Congenital MND is caused by an abiotrophy that affects GSE neurons, especially in the spinal cord. It occurs in young dogs and is commonly recognized as soon as the puppy begins to walk. It progresses at variable rates, depending on the nature of the genetic abnormality. These are breed-related disorders. No descriptions of a congenital MND in the Labrador Retriever have been published. However, I have seen these lesions in the spinal cord and brainstem of a young Labrador Retriever that was euthanized because of a progressive LMN gait disorder. The most thoroughly studied canine congenital MND occurs in Brittany Spaniels. It has been described in the literature as hereditary spinal muscular atrophy. This is inherited as an autosomal dominant gene disorder and presents as 3 phenotypes. The puppies that are homozygous for the dominant gene have an accelerated form that results in clinical signs by 6 to 8 weeks of age with tetraparesis, difficult prehension, and dysphagia. By 3 to 4 months of age, the tetraparesis may progress to tetraplegia, along with severe neurogenic atrophy and associated limb deformities. Two phenotypes are seen in the heterozygote dogs. The intermediate form shows clinical signs of LMN tetraparesis at 6 to 12 months of age, and it slowly progresses to the inability to walk by 2 to 3 years of age. The chronic form consists of a subtle paresis that is not observed until a few years of age and is accompanied by mild neurogenic atrophy. An example of a multisystem neuronal abiatrophy occurs as an autosomal recessive inherited disorder in Swedish Lapland dogs. Clinical signs of LMN paresis are seen as the puppies start to walk at 5 to 7 weeks of age. Tetraparesis progresses to recumbency by a few months of age and is associated with severe neurogenic atrophy and deformity of the limbs, which is referred to as arthrogryposis. The latter contractures are the result of the shortening of the denervated skeletal muscles in the rapidly growing dog relative to the normally growing bones. The disparity in growth between the bones and the muscles results in the fixation of joints in a flexed, carpus or extended stifle, tarsus, position. Arthrogryposis refers to this abnormal angulation of the limb. These dogs have an extensive abiatrophy of GSE neurons in the spinal cord ventral gray columns but also of neurons in the spinal cord dorsal gray columns, spinal ganglia, and Purkinje neurons in the cerebellar cortex. The clinical signs all relate to the loss of the GSE neurons. You cannot expect to appreciate cerebellar ataxia in an animal with diffuse LMN disease. This disease was studied in the 1970s and was successfully eradicated by careful selection of dogs for breeding. We studied a similar multisystem abiatrophy in 2 Doberman Pinscher puppies, in a litter of 8, that began to walk at about 4 to 5 weeks of age and then rapidly developed LMN tetraparesis and became recumbent, with severe muscle atrophy and rigidity of limbs caused by the shortening muscles and the growing bones. See in Video 5-24 a 9-week-old male Saluki that for 2 weeks exhibited a progressive gait abnormality and thoracic limb deformity. This was the second in a litter of 7 puppies to be affected. The other affected pup was euthanized without study. Note the bilateral thoracic limb arthrogryposis with abducted shoulders, flexed carpi with slight varus deformity, and hentobrachial supination. The pelvic limbs were short-strided, occasionally were protracted together, bunny-hopped, and slid out on a slippery surfaces. Occasionally, the neck was held partially flexed. These clinical signs were persistent and not related to exercise. Spinal reflexes were normal and muscle atrophy was mild. Cranial nerves were normal. Electrodiagnostic testing revealed diffuse denervation potentials in axial and appendicular muscles and normal conduction times but with a decrease in the amplitude of the muscle response. The anatomic diagnosis was a diffuse neuromuscular disorder. Autopsy revealed an abiatrophy of GSE, LMN cell bodies in the ventral gray columns bilaterally in all of the spinal cord segments with no lesions in the brain. An inherited basis for this motor neuron disease was suspected but not proven. The arthrogryposis was related to the young age of this patient when denervation occurred. An inherited congenital MND limited to the spinal cord GSE neurons has been described in Rottweiler puppies in which the signs include regurgitation caused by the associated megaesophagus. This is inherited as an autosomal recessive gene disorder. A similar diffuse spinal cord GSE abiatrophy is inherited as an autosomal recessive gene disorder in brown Swiss calves. These calves usually show clinical signs of progressive LMN tetraparesis before 1 month of age. Focal forms of neuronal abiatrophy have been reported but are rare. In 1936, Dr. Stockard was studying the musculoskeletal system of large breed dogs by mating Great Danes with bloodhounds and St. Bernards. In a few litters, some puppies developed a rapidly progressive LMN paraparesis and priapism at 11 to 14 weeks of age. This was determined to be an inherited abiatrophy of lumbar GSE and GVE sympathetic preganglionic neurons. To our knowledge, this has never been diagnosed outside this laboratory experimental setting. In 1989, Dr. John Cummings published observations of a focal abiatrophy of GSE neurons limited to the cervical intumescence in 2 littermate German Shepherd puppies with progressive thoracic limb LMN paresis. We have also studied 2 littermate Doberman Pinscher puppies with a similar abiatrophy of GSE motor neurons in the intumescences, which resulted in their recumbency with thoracic limb contractures by the age of 6 weeks. Equine motor neuron disease, acquired equine motor neuron disease, EMND, is an acquired disorder of adult horses that is strongly associated with an inadequate amount of vitamin E in the diet. As a rule, it occurs in adult horses, especially those that have been kept for a long period in a riding stable and fed hay and some grain, with no access to pasture. The most common chief complaints are generalized weakness, fatigue, and weight loss. The loss may be as much as 200 to 300 pounds, even though these horses have good appetites, because the weight loss is secondary to the denervation atrophy associated with the MND. The owner often observes the weight loss 3 to 6 weeks before recognizing the other clinical signs. Paresis is usually subacute in onset and progresses and does not usually occur until about 30% of the GSE neurons are lost from the spinal cord ventral gray columns. Figures 5-20 through 5-22. Owners recognize that the affected horse is less active, does not perform as expected, trembles, and spends much more time lying down when in its stall. When you examine this horse, you will note that it acts uncomfortable when just standing. It keeps all of its limbs placed inappropriately under its trunk, that is, capped under, rather than assuming its usual stance. It continually shifts its weight from one limb to another, trembles in the muscles in all 4 limbs, sweats excessively, and holds its head and neck in a lowered, flexed position. You will observe that this horse will be unable to lock its stifles to help support its weight. In more chronic cases, the tail may be carried in a slightly elevated position, and occasionally, a bizarre string halt-like movement may be seen as the limbs are protracted. These 2 clinical signs may be the result of denervation atrophy and fibrosis of affected muscles. These horses, without a doubt, prefer to walk rather than stand, which relates to the predilection of the MNG for the GSE neurons that have the most active oxidative metabolism and that innervate the type 1 anti-gravity postural muscles. The observation that affected horses walk better than they stand is a very reliable guideline for separating equine motor neuron disease from virtually all other equine spinal cord diseases. The affected horse walks with short strides and circles with no delay in the onset of protraction. No evidence of any ataxia is seen. When returned to its stall, the horse usually immediately starts circling to lie down. Once the horse is down, it will act much more comfortable and will eat as soon as feed is offered. When not eating, it often rests its chin on the ground to support the weight of the head and neck. All of these clinical signs relate to the increased effort of supporting weight because of the loss of neurons to the postural muscles. Video 5-25 shows Forget-Me-Not, a 9-year-old male thoroughbred with a history and many of the clinical signs that were just described. It is believed that the GSE motor neurons that innervate the type 1 postural muscles have the most active oxidative metabolism, and their degeneration is the result of the oxidative stress that is created by an imbalance between pro and antioxidants in the CNS tissues. The most significant of these is the dietary deficiency of the antioxidant vitamin E, which may be documented by determining low serum levels of vitamin E in these horses. Decreased levels of superoxide dismutase are evident in the CNS and blood. This enzyme normally converts the highly toxic superoxide radical into hydrogen peroxide. No recognized genetic abnormality exists in the equine genome to explain these low levels. Therefore, they may reflect an overwhelming of this system by the patient's need for antioxidant activity, increased levels of copper present in the nervous system and of iron in the liver and in the visible dental tartar on the incisors. Both of these are pro-oxidant catalysts for the production of highly toxic hydroxyl ion radicals that initiate lipid peroxidation and may contribute to the neuronal oxidative stress. Other components of the pathogenesis of this disorder may exist, but all studies strongly support the deficiency of vitamin E as the most significant cause. In support of this, clinically normal adult horses that have low vitamin E levels when purchased will develop the identical clinical signs and lesions of equine motor neuron disease when maintained on a diet deficient in vitamin E for about 2 years. Video 5-26 shows Tika, a 12-year-old saddle horse, with clinical signs of equine motor neuron disease that resulted from being fed a vitamin E deficient diet for about 2 years. At autopsy, the microscopic lesions were identical to those in natural cases of this disorder. Figure 5-23 retina of a horse with equine motor neuron disease, EMND, showing a mild excessive accumulation of lipofuscin in the pigment epithelium of the retina and in the space between the layer and the photosensitive layer. In subacute to chronic cases with the anatomic diagnosis of diffuse NMD, the only significant disorder that explains the clinical signs is equine motor neuron disease. The occasional case of a horse with very acute onset may be confused with cases of botulism or acute diffuse exercise-induced rhabdomyolysis. For botulism, look for some evidence of a pyretic tongue, pyretic facial muscles, dysphagia, and anal and tail hypotonia. For rhabdomyolysis, look for elevated serum muscle enzyme levels. A number of ancillary procedures help support the diagnosis of equine motor neuron disease. 1. The serum levels of vitamin E are usually extremely low. 2. In most affected horses, biopsy of the sacrocaudal dorsomedial muscle at the base of the tail, using a sacrocaudal epidural local anesthesia, reveals denervation atrophy in this muscle, which normally consists of a large component of type 1 muscle fibers. 3. In most affected horses, biopsy of the branch of the spinal axis soria nerve to the sternocephalicus muscle, where it enters the muscle at the origin of its tendon near its termination on the mandible, reveals Wallerian degeneration in the neuronal processes. 71. This degeneration follows the loss of the cell bodies of these neuronal processes in the cervical spinal cord ventral gray column. However, general anesthesia is usually necessary for this procedure. 4. Fundic examination reveals a yellowish discoloration in the retina in about 30% of affected horses. It results from the accumulation of retinal lipopigment that occurs in this disease. The associated retinal degeneration is enough to be determined on electroretinography, but clinical evidence of any visual deficit has not been observed. Figures 5-23 through 5-25. Treatment with vitamin E supplements and access to good quality pasture will stop the progress of the disorder, and some improvement may be seen, but a return to the athletic activity of the horse prior to clinical signs should not be expected because some degree of paresis and atrophy will persist. The disorder is readily prevented by providing a good source of vitamin E in the diet. Now that equine motor neuron disease is well known in the equine industry, vitamin E supplementation is a normal husbandry practice, and the incidence of clinical cases has decreased significantly. Equine motor neuron disease is an important animal model for a similar sporadic acquired MND in humans, which is known as amyotrophic lateral sclerosis, ALS, or Lou Gehrig disease. NMD monoparesis, thoracic limb, dog signalment, 10-year-old male Labrador Retriever, moose chief complaint, lameness in the left thoracic limb history. For the past 6 months, this dog has exhibited a lame gait in the left thoracic limb, and it has slowly progressed. Numerous orthopedic examinations, including radiography, have been normal. Examination. Video 5-27 showed moose walking normally in all limbs except the left thoracic limb, which he carried flexed at the elbow. Musculocutaneous nerve C6, C7, with the carpus bouncing on the floor, usually on its dorsal surface because of the inability to extend the carpus. Radial nerve C7, C8, T1. The dog hopped well on the 3 normal limbs but collapsed if any weight was placed on the left thoracic limb. Radial nerve. When the limb was manipulated, no tone was present in the carpus. Radial nerve. Median and ulnar nerve C7, C8, T1, T2. On elbow extension, resistance was felt in the elbow flexors. Musculocutaneous nerve. On muscle palpation, only mild atrophy was perceived in the lateral scapular muscles. Suprascapular nerve C6, C7, and it may be the result of disuse. Significant atrophy was seen in the triceps muscle, radial nerve, and in all the antebrachial muscles. Radial nerve cranially, median and ulnar nerves caudally. The superficial pectoral muscle was normal. Cranial pectoral nerve C6, C7, whereas the deep pectoral muscle was atrophied. Caudal pectoral nerve C8, T1. No cutaneous truncee reflex was present on the left side. Lateral thoracic nerve C8, T1, but moose perceived the forceps stimulus. Sensory testing of the skin of the left thoracic limb did not reveal any areas of analgesia. Hypalgesia was difficult to determine with any degree of confidence. Palpation of the axilla and the ventral branches of C7 and C8 while they crossed the cranial surface of the first rib was normal. Pupil size was normal. Anatomic diagnosis. Left, C7, C8, T1, and T2 spinal cord segments, spinal roots, Spinal nerves and their ventral branches, the brachial plexus, the radial, median, ulnar, caudal pectoral, and lateral thoracic nerves. Differential diagnosis: malignant nerve sheath neoplasm, intervertebral disc protrusion, lymphoma, brachial plexus neuritis, chronic neuritis. Malignant nerve sheath neoplasm. Malignant nerve sheath neoplasm is the most common nerve neoplasm in the dog. It is usually located in spinal nerves, their roots, or both, where it occasionally may compress the spinal cord. 14. Involvement of the cervical spinal nerves is the most common site. This has to be the first consideration in moose. The dog in this case example. Occasionally, the mass extends into the brachial plexus and is palpable in the axilla. It was not palpated in moose. Sometimes, these neoplasms cause considerable discomfort to the animal, and it is difficult to determine how much of the lameness is caused by the discomfort and how much by the inability to support weight. EMG will confirm denervation when it is difficult to differentiate a neurologic disorder from an orthopedic disorder, but it will not indicate the cause of the denervation. Although significant atrophy commonly follows the denervation associated with a nerve sheath neoplasm, the clinician must be aware that disuse atrophy may be surprisingly severe. It is common to find that a portion of the neoplasm is located in the vertebral canal or is growing into it along the course of the spinal nerve through the intervertebral foramen. In time, this will result in compression of the spinal cord, and additional clinical signs will be observed. Figures 5-26 through 5-28. The compression may be extradural, or if the nerve roots are involved, it may be intradural and extraparenchymal. Occasionally, both forms of compression occur. When this neoplasm grows in the spinal nerve at the level of the intervertebral foramen, it may cause the bone to be resorbed, resulting in an enlargement of that foramen, which can be observed on radiographs. EMG will support this diagnosis when significant involvement of the vertebral canal has occurred. MRI is the ancillary procedure of choice because it can help diagnose a neoplasm that lies anywhere between the axilla and the vertebral canal. The index of suspicion for a malignant nerve sheath neoplasm should be raised when a patient like moose is presented with an obvious lameness that is chronic in duration and an orthopedic explanation cannot be made. It must be kept in mind that dogs with orthopedic disease are lame because of discomfort or a decreased range of movement caused by a mechanical reason for inability to flex or extend joints, as occurs with degenerative joint disease. In the absence of an orthopedic explanation, the nervous system must be considered. When patients are referred for an undiagnosed lameness, along with a large collection of normal radiographs, most likely a neurologic explanation exists for the gait abnormality that includes a malignant nerve sheath neoplasm. Surgery is the treatment of choice, but this neoplasm is so locally invasive that it extends into many nerve branches, making it very difficult to remove all of the neoplasm. Recurrences are common in a few months. In a case like moose's, in which no clinical signs are present to support the growth of a neoplasm in the vertebral canal, you should always evaluate the latter by advanced imaging to help determine the prognosis and how extensive the surgery should be. If, as far as you can determine, the neoplasm involves primarily the brachial plexus, then amputation is the only surgical alternative. However, be aware that the neoplastic cells most likely are growing proximally in the ventral branches of the spinal nerves that contribute to the brachial plexus and in the spinal nerves themselves, in which location they are difficult to remove with the limb. Figure 5-29. The prognosis for long-term recovery is guarded. Always remember to carefully evaluate the patient's ipsilateral pelvic limb for any paresis and ataxia that would suggest growth of the neoplasm within the vertebral canal and resulting spinal cord compression. A degenerated intervertebral disc that extrudes laterally into an intervertebral foramen and compresses the spinal ganglion and nerve located there is a common cause of lameness in one thoracic limb. However, this lameness is more the result of the discomfort caused by the compression of the meninges associated with its spinal ganglion or nerve than the loss of motor neurons to extensor muscles. In moose, much more evidence of inability to support weight than of discomfort was present, and the distribution of the neurogenic atrophy could not be explained by compression of a single spinal nerve. Radiography and MRI help support this diagnosis of intervertebral disc protrusion. Surgical removal of the protrusion is recommended. Brachial plexus neuritis. Brachial plexus neuritis is a rare cause of LMN signs in one or both thoracic limbs. This usually is a very acute disorder and would not be a consideration in moose. The dog in this case example. The pathogenesis is poorly understood, but an allergic response that causes swelling of the spinal nerves at their intervertebral foramina has been proposed. We studied one Great Dane dog with an acute onset of brachial plexus neuritis in both thoracic limbs, and the condition was associated with eating horse meat. Chronic neuritis. A chronic neuritis affecting the brachial plexus or its branches is more compatible with the prolonged history of slow progression of clinical signs in moose. This is an unsuppurative neuritis that probably is an autoimmune disorder. Involvement of only one limb would be unusual. We observed a chronic hypertrophic neuritis in a 6-year-old golden retriever, and the neuritis was most developed in the C7 and C8 spinal nerves on one side and caused clinical signs very similar to those seen in moose. The involvement of the spinal nerve roots was seen on CT imaging. The diagnosis was made on the basis of the histologic examination of the enlarged C7 nerve roots that were removed surgically. A nerve sheath neoplasm is more likely to result in greater nerve enlargement compared with a chronic hypertrophic neuritis. MRI is necessary to determine the degree of extravertebral nerve enlargement and to diagnose involvement of the nerves in the vertebral canal when no displacement of the subarachnoid space has occurred. EMG requires the latter to be diagnostic. Definitive diagnosis requires biopsy of an involved nerve. Bilateral hypertrophic neuritis of the brachial plexus has been diagnosed in a cat by means of MRI. Brachial plexus root avulsion of all or a portion of the roots of the brachial plexus is a peracute severe neurologic disorder caused by a motor vehicle accident. It would not be considered in explaining the clinical signs in moose. The dog in this case example. However, the character of the neurologic signs causing the lameness in this dog is similar to that which follows an injury that tears some of the spinal nerve roots or the spinal nerves, or both, that contribute to the brachial plexus. This would be a partial avulsion. Video 5-28 shows Kaiser, a 6-month-old German Shepherd dog, 2 days after being struck by a car. The inability to support weight is caused by the loss of function of the radial nerve, C7, C8, T1. In this dog, the injury spared the C6 and possibly some of the C7 roots, enabling the dog to advance the limb by extending the shoulder, suprascapular nerve, C6, C7, nerve to brachiocephalicus muscle, C6, and to lift the limb off the floor by flexing the elbow, musculocutaneous nerve, C6, C7. The area of analgesia is in the autonomous zone of the radial nerve. Meiosis was observed in the right eye. This places the lesion at the level of the spinal nerve roots or spinal nerves before they branch. Always carefully examine the eyes of these dogs. Avulsion of the ventral roots of T1 or of the T1 spinal nerve will cause a meiosis because of the interruption of the GVE preganglionic neuronal axons located there that provide sympathetic innervation to the eye. An elevated third eyelid ptosis require interruption of of the ventral roots of the T2 and T3 spinal cord segments. The GSE neurons to the thoracic limb and the GVE neurons to the head can be simultaneously affected only at this level. The same GSE, LMN paralysis observed in the thoracic limb would occur if the injury were located within the brachial plexus. But this lesion could not have affected the GVE innervation of the head because those preganglionic axons leave the GSE axons just external to the intervertebral foramen, where the ramus communicans leaves the spinal nerve to join the cranial portion of the thoracic sympathetic trunk. MR images obtained in Kaiser suggested a lesion at the nerve root level without an avulsion. This dog was much improved after 1 month. See video, and was normal by 6 weeks, which supports the resolution of hemorrhage and edema and not a tearing avulsion of the nerve roots. The majority of these injuries causes a nerve root or spinal nerve avulsion of most of the spinal nerves that contribute to the brachial plexus. Figures 5-30 and 5-31. This causes complete flaccid LMN paralysis of the affected limb. Video 5-29 shows Luke, an 8-year-old Labrador Retriever mixed breed. The dog was struck by a car while being used in a narcotic search. This occurred 2 weeks before the video was taken, and no change had occurred in the dog's clinical signs in that time. The video shows the limb hanging beside the body and being dragged, limp and useless, as the dog walks or runs normally on the other 3 limbs. The paralyzed limb is atonic, areflexic, and entirely analgesic distal to the elbow and in patches proximal to it that represent autonomous zones supplied by the C6 to T1 spinal nerve roots. This analgesia represents the loss of axons as a result of the avulsion of the dorsal roots from C6 to T1. Note the analgesic patch just caudal to the neck of the scapula, which is the autonomous zone of the cranial laterocutaneous brachial nerve, axillary, C7, C8, but the immediate nociceptive response just caudal to it, which is innervated by laterocutaneous branches of the second or third thoracic spinal nerve. The cutaneous truncee reflex contraction was present on the right but not the left when the skin on the dorsal midline was pinched with forceps at any thoracic level. Lateral thoracic nerve, C8, T1. There was meiosis in the left eye, T1, preganglionic sympathetics. Surgical reattachment of the torn ventral roots to the surface of the spinal cord to provide a guide for neuronal reinnervation has shown some success experimentally. Because your clinical examination can define only the degree of functional neurologic deficit and not the actual structural disorder responsible for it, that is, hemorrhage and edema or an avulsion. It is important to provide supportive care for a few weeks to allow for recovery of the occasional dog that does not have an avulsion. If no indication of recovery is apparent after at least a 6-week period, the paralyzed limb should be amputated because it will impede the dog's effort to move freely and may easily become abraded and infected, resulting in osteomyelitis, sepsis, and even death. If, during the waiting period, the dog begins to chew excessively on the limb or abrades it extensively, the limb should be amputated. Dogs with only one thoracic limb do very well in most activities except swimming. Owners are often hesitant to elect amputation because of the aesthetics involved. It may be very helpful for them to see how well a dog actually does after an amputation. We recommend that a video of one of these dogs with an amputated thoracic limb be made to help reluctant owners appreciate the extent to which these dogs can enjoy a good quality of life. We have made this diagnosis of a brachial plexus root avulsion in cats and in many species of birds. Video 5-30 shows Starlene's right thoracic limb lameness. In the absence of any discomfort on weight bearing and with a normal orthopedic examination, including nerve blocks, the lameness must be considered an inability to support weight and must therefore involve some component of the radial nerve. The degree of atrophy could be caused by disuse or could be neurogenic. No loss of nociception in the right thoracic limb was seen, but it must be kept in mind that the horse is the only domestic animal in which the radial nerve has no autonomous zone for the branches that provide cutaneous innervation. On cranial nerve examination, the only abnormality was the deviation of the nose and lip to the left side. Anatomic diagnosis: C7, C8, and T1 spinal cord segments, spinal nerve roots, spinal nerves, the brachial plexus, the radial nerve, and the buccal branches of the right facial nerve. Differential diagnosis: equine protozoomyelitis, malignant nerve sheath neoplasm, lymphoma, polyneuritis equi. Other neoplasms: equine protozoomyelitis caused by Sarcocystis neurona is the most common cause of inflammatory spinal cord lesions in the horse and is more completely described in Chapter 11, which discusses spinal cord diseases in large animals. This form of myelitis involves both gray and white matter and occasionally is nearly limited to one area of gray matter and therefore must be a strong consideration as a diagnosis in this horse. Usually, a gray matter lesion involves adjacent white matter, which, at the level of this anatomic diagnosis, could affect the UMN and GP systems running to and from the right pelvic limb. No pelvic limb signs were seen in Starlene. The normal lumbar CSF analysis in this horse would not rule out this diagnosis. The horse received anti-protozoal treatment based on this diagnosis for 2 weeks but showed no improvement. Malignant nerve sheath neoplasm would be the most presumptive clinical diagnosis in a dog of this age and with these clinical signs and progressive history, but to our knowledge, this diagnosis involving spinal nerves has not been reported in the horse. In addition, it would not explain the facial nerve involvement. Lymphoma would be the most presumptive diagnosis in a cat of this age and with these clinical signs and history. In cats and cattle, extradural lymphoma is a common cause of progressive spinal cord compression. Occasionally, in cats, the lymphoma develops and grows within nerves. nerves. Involvement of a spinal nerve and its roots may cause an intradural extraparenchymal spinal cord compression. Polyneuritis equitypically involves the nerves of the cauda equina and occasionally cranial nerves. Although it has rarely been reported in other spinal nerves, it would be an unlikely cause of the anatomic diagnosis in this horse. See case example 5-9 for an example and description of this equine disease. Spinal cord neoplasms are rare in horses of any age. When this horse did not respond to antiprotozoal therapy, the owners requested euthanasia. The autopsy diagnosis in this horse was intramural lymphoma that involved primarily the C8 spinal nerve roots, without spinal cord compression, the C8 spinal nerve and its ventral branch, and a portion of the brachial plexus. Figures 5.32 through 5-35. The clinical signs reflected the major contribution of the C8 spinal nerve to the radial nerve. The same lesion was present in the buccal branches of the right facial nerve. Figures 5-36 through 5-38 show an 18-month-old domestic short-hair cat with a similar infiltrating lymphoma affecting the left C7 and C8 spinal nerves and their roots. Equine protozoa myelitis. Video 5-31 shows a 4-year-old thoroughbred gelding that had raced 10 days before he fell in the crossed eyes and exhibited a reluctance to walk and lameness in both thoracic limbs. Note the normal pelvic limb gait and the hesitant short strides in the thoracic limbs. The right thoracic limb is slightly worse and has mild atrophy of the lateral scapular muscles. The anatomic diagnosis is C6 to T2 spinal cord ventral gray columns, spinal nerve roots, and spinal nerves. The differential diagnosis is the same as in this case example. The serum was positive for antibodies to S. neurona. CSF was normal. This horse was treated with antiprotozoal drugs but became recumbent 2 days later and was euthanized. Autopsy revealed an extensive hemorrhagic myelitis centered in the ventral gray columns of the cervical intumescence bilaterali. Protozoal organisms were found in the lesion. Figure 5-39. Injury. Video 5- Injury. Video 5-32 shows a 6-month-old male thoroughbred that was found at pasture with a severe non-weight bearing left thoracic limb lameness. Note the drop position of the elbow and the complete inability to support weight. Palpation and manipulation of this limb caused no discomfort and revealed hypotonia. This is a complete radial paralysis presumed to be caused by an injury of the radial nerve at the level of the brachial plexus as a result of some form of trauma that occurred while at pasture. About 50% of young horses with these signs, including this one, recover spontaneously. Autopsies in a few of these cases show lesions compatible with an injury of the brachial plexus, where it lies between the scapula and the first rib. A spinal nerve root avulsion has not been diagnosed in the horse. Compare video 5-30 of this 6-month-old thoroughbred with Video 5-33 of a 15-month-old Belgian, which had been lame in the right thoracic limb since being kicked in the region of the elbow a few days before. The swelling had disappeared but not the lameness. Note the ability of this Belgian to support weight with the hesitation in the extension of the carpus and digit because of the injury of the distal portion of the radial nerve. After innervating the extensors of the elbow, the radial nerve courses distally on the lateral surface of the brachialis muscle, where it terminates in muscular branches to the extensors of the carpus and digit and in cutaneous branches to the cranial and lateral surfaces of the interbrachium. The cutaneous distribution overlaps with the cutaneous branches from other nerves, so no autonomous zone exists for the radial nerve in the horse. This Belgian was kicked at the level of the elbow, where the radial nerve is subcutaneous on the surface of the brachialis muscle. The same signs are seen in dogs that are injured at this site in motor vehicle accidents. Likewise, cats undergoing a declawing procedure may suffer an injury to the muscular branches of the radial nerve from the pressure of the tourniquet that is placed proximal to the elbow. Video 5-32 shows a 6-month-old male thoroughbred that was found at pasture with a severe non-weight bearing left thoracic limb lameness. Note the drop position of the elbow and the complete inability to support weight. Palpation and manipulation of this limb caused no discomfort and revealed hypotonia. This is a complete radial paralysis presumed to be caused by an injury of the radial nerve at the level of the brachial plexus as a result of some form of trauma that occurred while at pasture. About 50% of young horses with these signs, including this one, recover spontaneously. Autopsies in a few of these cases show lesions compatible with an injury of the brachial plexus, where it lies between the scapula and the first rib. A spinal nerve root avulsion has not been diagnosed in the horse. Compare video 5-30 of this 6-month-old thoroughbred with video 5-33.